So the next lecture will be delivered by Dr. Lalana Devi Ranasinghe, who's the consultant endocrinologist, District General Hospital, Embilipitiya. She will discuss about the perplexing cases of Graves' disease.
Thank you for the kind words of introduction. So let me take you through three different cases. So the first case is a 64-year-old male with hypertension, admitted with ischemic type of chest pain, and he was suspected to have thyrotoxicosis because he was tachycardic, and he was experiencing thyrotoxic symptoms. He was a non-smoker, no family history of thyroid disease. He's a farmer from a poor socioeconomic background. So on examination, no eye signs, moderate size of a goiter with a bruit, no features of heart failure, pulse rate was 130 beats per minute, regular rhythm, and ECG confirmed sinus tachycardia. So thyroid function shows thyrotoxicosis with very high T4 levels, so it's severe thyrotoxicosis, and ultrasound findings are in keeping with Graves' disease with a diffuse goiter, increased vascularity, and heterogeneous echogenicity. So as this patient presented with ischemic type chest pain with tachycardia, initially treated with IV verapamil, and then he was started on beta blockers and carbimazole 20 milligram TDS. And after 1 month, he was feeling better, but still having some symptoms, and pulse rate still 100 beats per minute. And if you look at T4 level, it has come down, but it is still raised at 3 nanograms per deciliter. And he claims to have a good compliance. So, based on this clinical picture, I think you can appreciate that this is a patient who will need long-term antithyroid drug treatment. So these are the other treatment options. This is a patient who is not going to be controlled with long-term antithyroid drug treatment. So the other treatment options include thyroid ablative therapy like thyroidectomy and radioactive iodine treatment. So he's less likely to respond to long-term antithyroid drugs because he's a male with a moderate size of goiter and very high T4 levels at presentation. And we discussed about definitive treatment options, radioactive iodine treatment and surgery. Even though radioactive iodine treatment seems to be the best option, this patient wanted to go ahead with surgery due to various reasons. So as clinicians, our duty is to make this patient euthyroid prior to surgery. So why are some patients not responding to thionamide drugs as we expected? Well, this refractory thyrotoxicosis could be due to various reasons. It may be because there is malabsorption of drugs, rapid drug metabolism due to thyrotoxic state. There may be antithyroid drug antibodies, or there may be impairment of intrathyroid drug accumulation or action. So in this sort of situation, what are the adjunctive treatment options that we have? And this include glucocorticoids, iodine, cholestyramine, and lithium carbonate. And if you look at literature, some people have even tried plasma exchange to rapidly lower T4 levels in patients who have adverse reactions to thionamide drugs and who is having severe complications like atrial fibrillation with heart failure. So I will go through each of these drugs, individual drugs briefly. So moving on to glucocorticoids, you all know that it has an immunosuppressive effect and it does reduce T4 to T3 conversion. And if you look at the dose, some people have used high dose of prednisolone like 1 milligram per kg per day, whereas some have used low doses like 20 milligrams per day with a very good response. So if we are planning for radioactive iodine treatment, then use of a steroid seems all right, but if you are planning for a surgery, there are certain things to consider. So can steroid use during this pre-op period can it increase rate of infections? Can it cause adrenal suppression? And can it precipitate adrenal crisis during surgery? So these are the things that we are concerned about. So if you look at this study, this is a very small study, 10 patients with Graves' disease with severe thyrotoxicosis who had major adverse reactions to thionamide drugs. And these patients were treated with what is called rapid thyroid hormone blocking protocol for 10 days prior to surgery. And they used 3 drugs, lugolzidine, dexamethasone, and beta blockers to keep resting heart rate less than 80. So they used dexamethasone 1 milligram per BD the equivalent prednisolone dose would be 13 milligrams, it's a low dose, and DEXA was continued a few days after surgery and then converted to hydrocortisone, and it was given for 4 to 6 weeks, and after that adrenal function was checked. So if you look at results, here you can see the T4 and T3 levels, free T4 and free T3 levels. Day 10 is the day of surgery, and by that time, most of these patients, all of these patients had either normal or slightly raised free T4 levels. And all of these patients were clinically euthyroid by the time of surgery with controlled heart rate and no peri and post-op complications. So 2 patients developed adrenal insufficiency 4 to 6 weeks after surgery, and these patients recovered adrenal function after 3 to 6 months. So this is a case series looking at 4 young patients. These patients were treated with prednisolone 30 milligram daily for 2 weeks prior to surgery with potassium iodide plus or minus antithyroid drugs. So all of these patients achieved euthyroidism prior to surgery with no post-op complications. And if you look at one of these patients, this is the T4 levels of one of these patients, and here you can see that this patient has received steroid cover for surgery. So moving on to iodide, potassium iodide act mainly by blocking thyroid hormone release, and also it reduces hormone production as well. So 2 iodide preparations that we have include Lugol's iodine and SSKI, saturated solution of potassium iodide. So these drugs are generally continued 10 days prior to surgery. And if you look at this meta-analysis, including 500 odd patients, it revealed that pre-op iodine use reduces the vascularity of the thyroid and also intra-op blood loss. However, if you look at post-op complications, there is no additional benefit. So the problem with use of potassium iodide is this escape phenomenon. The efficacy can be lost with time. However, some studies have shown that potassium iodide can be used for long-term, to achieve euthyroidism in patients with Graves' disease. So this is a small study looking at 44 patients with Graves who developed side effects to thioneamide drugs, and these patients were treated initially with potassium iodide alone. So majority of these patients, 66%, were well controlled with iodide alone, and 38% of total patients achieved remission after 7 years. And those who required low dose of iodide to achieve euthyroidism, less than 200 per day, were more likely to go into remission compared to higher doses. And those who were not controlled with iodide alone were treated with iodide plus low-dose thioneamides, and some of these patients also went into remission after 7 years. This is again another small study. Here they treated Graves' disease with severe thyrotoxicosis with 2 regimes. One group received high-dose methimazole, 30 milligrams per day, and the other group received methimazole plus low-dose methimazole, 15 milligrams per day, plus potassium iodide. And this was a short-term study, 60 days. So if you look at free T4 normalization rates at 60 days compared to methimazole, the methimazole alone, this group, those who were treated with combination had lower rates of toxicity, and they had higher rates of T4 normalization at 30 days and 60 days. Moving on to cholestyramine. Cholestyramine is an ion exchange resin which blocks the intrahepatic circulation of which blocks the intrahepatic circulation of thyroid hormones, and therefore it is effective in reducing T4 levels due to any cause, including iatrogenic thyrotoxicosis. You can use it. So if you look at this study, this is again a small study, 30 patients with newly diagnosed Graves, severe thyrotoxicosis. Let's concentrate on these 2 groups, group 1 and group 2. So group 1 received methimazole plus cholestyramine. Group 2 received methimazole alone. Both groups received beta blockers. So if you look at percentage reduction of T4 from baseline at week 2 and week 4, at week 2, Group which had the combination treatment had additional 20% reduction of T4 levels, and at week 4, 10% additional reduction in T4 levels. Moving on to lithium carbonate, it inhibits thyroid hormone release, and the problem with lithium is that it has a narrow therapeutic range. Therefore, you have to monitor lithium levels, and you have to be very cautious when you're using lithium in certain groups of patients, especially elderly. However, if you are planning for radioactive iodine treatment, lithium has some added benefits. Lithium causes retention of iodine within the thyroid, and therefore it enhances efficacy of radioactive iodine, and also it may prevent T4 increase after antithyroid drug withdrawal prior to radioactive iodine. So if you look at ATA guidelines, in exceptional circumstances when it is not possible to render a patient with Graves' euthyroid prior to surgery, they also says that you can use a combination of drugs, beta blockers, potassium iodide, glucocorticoids, and potentially cholestyramine in the immediate pre-op period to control thyroid hormones. And in this circumstance, you need to have an experienced team, experienced surgeon and anesthetist. So this is a strong recommendation based on low quality evidence. So moving back to our patient, this patient was treated with a combination of carbimazole, lugolcidine, prednisolone with beta blockers during pre-op period, and he underwent thyroidectomy with stress dose of hydrocortisone and no post-op complications. So let's move on to case 2. This is a 35-year-old lady, a pregnant mother, 8 weeks. She's a known patient with Graves' disease with thyrotoxicosis. Carbimazole started 6 months ago. This is an unplanned pregnancy. She was seen by obstetrician. He changed carbimazole to PTU, which is the correct thing to do, and then he was referred to us for further management and follow-up. So I just want to show you the thyroid hormone levels and the antithyroid drug requirement of this patient right up to 34 weeks. So the problem here is that if you look at guidelines, they say if a patient with Graves' disease is pregnant, monitor TRAB levels, TRAB or thyrotropin receptor antibody levels, to get an idea about fetal and neonatal thyrotoxicosis. However, in this patient, we couldn't do TRAB levels because it is not available in government sector, and patient couldn't afford to do it. So let's see how you are going to, manage this sort of a patient. So TRAB or thyrotropin receptor antibodies, the maternal TRAB can enter fetal circulation and can cause a goiter and a thyrotoxicosis after formation of the fetal thyroid, and fetal thyroid usually becomes responsive to TRAB at around 20 weeks of gestation. And if you look at fetal characteristics of thyrotoxicosis, this include tachycardia, goiter, and accelerated bone maturation, and fetal thyrotoxicosis can cause complications like IUGR, oligohydramnios, cardiac failure, eye drops, and even IUD. So if you look at the natural history of Graves' disease during pregnancy, so we know that pregnancy has an immunosuppressive effect, and during pregnancy, usually the Graves' disease, the activity level goes down, and then there is relapse can occur post-delivery due to this immune rebound phenomenon. So if you look at what happens to TRAB levels, generally, as pregnancy advances, TRAB levels goes down. So if you look at ATA guideline, if it recommends to monitor TRAB levels during pregnancy if a patient with Graves' disease is having thyrotoxicosis during pregnancy. So you have to do TRAB levels during early pregnancy, and if it is positive, then check it during second trimester, 18 to 22 weeks. If positive, check it at third trimester, 30 to 34 weeks. So generally we expect TRAB levels to come down, and TRAB levels at 20 weeks gives us an idea about risk of developing fetal Graves. So if the TRAB level is more than 3 times upper limit of normal during this time, there's high risk of developing fetal Graves' disease. If TRAB levels are raised during third trimester at around 30 weeks, there's high risk of developing neonatal Graves. So what are the indications for fetal surveillance for hyperthyroidism? So if the TRAb level is raised, of course, we have to monitor for fetal thyrotoxicosis. Otherwise, if a woman is having uncontrolled hyperthyroidism in second half of pregnancy, that is another indication to do the fetal surveillance. So generally, we do it by ultrasound examination, and we look for presence of a fetal goiter, tachycardia, and low amniotic fluid index and IUGR. So ultrasound is quite specific and sensitive in detecting fetal thyrotoxicosis in good hands. So here's a study looking at 47 newborns of TRAb positive mothers. So out of these 47, 9 had neonatal hyperthyroidism and 5 needed antithyroid drugs. And all mothers of those neonates who developed thyrotoxicosis had raised TRAb more than 3 times upper limit of normal during second trimester. And all these mothers needed antithyroid drugs during late pregnancy. So if you look at what happens to the neonate, so at delivery, we know that maternal antithyroid drugs, they goes into the fetal circulation and control fetal thyroid function. So neonate has normal thyroid function at birth, but as time goes on, these maternal antithyroid drugs are metabolized and excreted, and the neonate becomes hyperthyroid. Here you can see that around day 7, this patient has become tachycardic. So neonatal thyroid function should be checked at delivery, and then again it should be rechecked at between 4 to 7 days. So coming back to this case, so since this patient required antithyroid drugs throughout pregnancy up to 34 weeks, even though the dose requirement has reduced over time, this is a patient with high risk of developing fetal as well as neonatal thyrotoxicosis, and fetal surveillance up to this period was unremarkable. Unfortunately, this patient was lost for follow-up after 34 weeks, maybe because after explaining all this, she must have gone to a better center. Right, okay. Let's move on to case 3. This is a 24-year-old lady, a young lady who presented with hypothyroid symptoms 6 months ago, and then at that point she had TSH of 8, and she was diagnosed with hypothyroidism and started on thyroxine. However, after starting thyroxine, she was losing weight, and then she was seen by GP, and GP stopped thyroxine. But she continued to lose weight, and therefore she was referred to me, and she had a small diffuse goiter, pulse rate 90 beats per minute, and thyroid function revealed thyrotoxicosis with suppressed TSH and T4 at 3.6. Ultrasound features were compatible with Graves' disease, and TRAb levels TRAb was positive. So this is a patient with Graves' disease who initially presented with hypothyroidism. So can patients with Graves present with hypothyroidism, and if they are hypothyroid, can they develop hyperthyroidism later on? Or can the vice versa, can it happen the other way? So we know that Graves' disease occurs due to TRAb or thyrotropin receptor antibodies, and there are several subtypes of TRAb: stimulatory TRAb and blocking TRAb. And if we look at these stimulatory and blocking TRAbs, these have some similar characteristics. They are of low concentration with high affinity, and both blocking and stimulatory TRAb, they have similar binding epitopes on the TSH receptor. The stimulatory TRAb activate the cyclic AMP pathway and increase T4 production, whereas blocking TRAb does not activate cyclic AMP pathway, and since it blocks TSH action on the receptor, it causes hypothyroidism. So here is an interesting study looking at patients with Graves' disease who had hypothyroidism due to blocking TRAb. And they studied 34 patients, and these patients were followed up to 10 years. And you can see, and TRAb levels were monitored during this period. So if you look at here, graph A, you can see that blocking these TRAb levels, remained stable during this period of time, and all of these patients who had elevated TRAb remained hypothyroid. And if you look at graph B, here you can see that TRAb levels are coming down with time, and most of these patients recovered from hypothyroidism. And here is graph CA and CB. So in CA you can see the blocking TRAb levels. So blocking TRAb levels are coming down, and here they have shown the stimulatory TRAb. Stimulatory TRAb levels are going up. So as blocking TRAb comes down and stimulatory TRAb going up, these patients, these hypothyroid patients, are becoming hyperthyroid. The other interesting thing was they looked at the effect of presence of a goiter, or presence or absence of goiter, the size of the thyroid on thyroid function. And the goitrous patients, those who had a goiter, all of them recovered from hypothyroidism later on. Whereas atrophic, or those who didn't have a goiter, most of them had persistent hypothyroidism. And based on these findings, they thought that, well, if you are having hypothyroidism with blocking TRAb, predominant blocking TRAb, and if you're having a goiter, you are more likely to recover from hypothyroidism. And if you're having, if there's no goiter, more likely to remain hypothyroid. But some exceptions are there. So moving back to our patient, so it is likely that this patient presented initially with hypothyroidism. It may be because she had predominant blocking antibodies at the beginning, and then later on she developed hyperthyroidism, maybe because she developed predominant stimulatory antibodies, maybe because she's having both antibodies in her circulation, and blocking antibodies are predominant at the beginning, and now stimulatory antibodies are becoming predominant. So this can happen. However, in our setup, we can't do these subtypes, so we just have the TRAb. We know the TRAb is positive or negative. We don't know which type of TRAb. But this can happen. So with that, I will conclude my presentation. Thank you very much.